those of you that do trauma know that one of the worst things you can hear is you got a kid coming in. I mean, the good news is a good portion of the time they heal well and they do well, but it's still one of the scariest things, at least for me. So I'm very glad to be able to introduce Kevin, who everybody knows, talk about pediatric trauma.
Okay. Well, thanks for having me today. Originally, thought this was supposed to be like a 20-minute thing, so I made a 20-minute lecture on minimally invasive surgery and peds trauma. And then Sam reminded me, no, it's actually supposed to be like a full lecture. So I found another topic, and that's why it's bipolar pediatric trauma rounds. And it's basically, I'm going to talk about minimally invasive surgery and pediatric trauma. And this is based on a really good, if you want more details, there's a really good article in the Surgical Clinics in North America that came out last month on this very topic. And then damage control and pediatric trauma. And it also has some algorithms. I'll have some pictures of the algorithms, but they're kind of detailed. But if you want more, I can get you a copy of this. It's currently in press, but it is available online. So, minimally invasive surgery and pediatric trauma. Unfortunately, I have nothing to disclose financially, and the target audience, pretty much everybody is here. So, all right. So, when we talk about minimally invasive surgery, it's really just a fancy term, sexy term for doing stuff with smaller incisions. And you might hear people say, oh, well, it's better than doing it open. It's not always better. And you might hear it say, well, MIS is like a term that minimally invasive surgeons may say their service is the MIS service or whatever. Not in this hospital, but in other places if you rotate other places. But you got to be careful. Minimally invasive surgery is not maximally effective surgery if it's misapplied. And in our terms of discussion, we want to talk about the fact that it should really only be applied when the chance of a negative laparotomy is high or the consequences of a negative laparotomy are high. And what do I mean by a negative laparotomy? You think there's a problem in there that you need to go in and fix. And you normally would do that by making a big incision and going in there and fixing it. But you know that there's a significant percentage of the time that you open this up and you don't find anything you need to repair. So you basically have done this. It gives you the satisfaction of knowing that you're not missing an injury, but you've created this huge wound and this big abdominal incision that's very painful, and that has consequences. So minimally invasive surgery for trauma in kids basically started off in two separate arms and kind of came together. In 1973, there was a group, I believe they were in France, that started doing what they used to call peritonoscopy is what they used to call this. It was through a big scope that you actually looked through. It had a light source on the side of it, kind of similar to what you would think a proctoscope would be, but smaller. And then a group in 77 was starting to do this for trauma, using the same types of equipment, but as a way to reduce the number of laparotomies. And so that idea started to come together more in the 90s. And in the 90s is when we started seeing them build laparoscopes and other equipment like the endoscope and things like that you had a camera on a chip, just like it is in your cell phone, but a miniaturized camera that could be placed inside a smaller device that allowed us through the fiber optic type of technology to see things better than we were before. We didn't have to put our eyes in there to look. We could actually look on a screen. And when that started becoming more utilized by general surgeons and general thoracic surgeons, that naturally carried over to trauma. And then same thing with pediatric surgery. We started using more and more laparoscopic stuff. Then they started applying it. And then in the early 90s, mid-90s, you started seeing some significant studies in the adult literature showing that they could reduce the negative laparotomy rate up to 60% in some of these studies. So it showed that there's definitely a usefulness for it when it's applied correctly. But early on, the main idea was basically to just reduce the negative laparotomy rate. No one was thinking of that we could actually fix something we found with a laparoscope. It was just basically, look in there, if we don't find an injury, we've only made some small holes, and we can close the holes up. Just about all the time that they found something, they would convert to open, and that's still reasonable today. If you're not really gung-ho about laparoscopy, you don't have to fix everything with a laparoscope, because you're still going to save a lot of kids an unnecessary laparotomy just by using the scope to look for a problem. But it was poorly adopted early on, and at the same time, the CT scanner technology was getting better. So there was less equivocal CT scans. There were less kids and adults that we were like, well, what do we do with this? Because our scanner got better, we could see better, And then we were able to qualify whether or not this was an abnormal finding or not, just because our CT scans were better. At the same time, you started seeing kind of earlier on in children and then later adapted to adults, this non-operative approach to solid organ injury. So that basically means if it used to be when I was a resident, if you had a spleen injury, that was a great excuse to go to the operating room and do a splenectomy. And everyone was excited when they did that. We took a bunch of spleens out and we realized that's a bad idea. We don't have to do that. Most of the time you have a spleen or liver injury, you don't need a surgery. And then this thing called a FAST exam came about. Now, FAST exam is, if you're not familiar with it, is an ultrasound, and you're looking at the 4 quadrants of the abdomen, the pelvis, the pericardium. You're looking for fluid in spaces that's not supposed to be there. Okay? So it's great for detecting fluid. It's a very, very good test for looking for free fluid if it's done correctly, and in a person whose size is not prohibitive for an ultrasound. But it's not great at telling you where the blood comes from, or if it's even blood. It could be urine, it could be bowel content, or bile even. It just tells you if there's fluid in an abnormal place. And because it's not that great at telling you where the fluid comes from, and because kids have such high injury rates with their liver and their spleen, they have a high number of positive FAST exams. And the reason is that if their spleens are really big and they get cracked and they bleed a little bit, well, your FAST exam is going to be positive. So a lot of people are like, well, why do we even do that? Just do a CAT scan. I can see, more information. And a CAT scan does give you better information. And then in the last decade or so, people have really been trying to hone in on, let's stop irradiating kids so much with CAT scans. We used to have more of an adult-type protocol for kids. It wasn't really based on their weight. And you kind of just would zap them with the CAT scan, and then the CT tech would then adjust the gate or the level to interpret it. And now they're like, well, we know they need less radiation. We have a better CT scanner now. We can zap them with less radiation to begin with. And then that's when we use the CAT scan. But why don't we just figure out who really needs a CAT scan and who doesn't, and then limit their use? And that's what one of those protocols is about, but we can't go into that. It takes too long to go over all that. But so that this has then pushed us back to use the FAST exam again, because it's part of those protocols. Let's use the FAST exam, and then we'll know who needs a CT and who doesn't. But again, it's not more specific than a CT, so we're still kind of in that conundrum. So there's still a significant number of kids that are in this kind of gray zone. And then you have people who are like, well, I can do any surgery with a laparoscope. Why not do everything with the laparoscope? Well, just because you can do it doesn't mean you should do it. And one person being good at it, I mean, this guy can publish a paper about it, but that doesn't mean I can do it, or Joe Blow can do it. It might be great if you happen to get injured in the place where the world's greatest laparoscopy trauma specialist guy is, or gal, but that's not widely applicable. So, and it takes longer to do that surgery. It's more expensive, and you can question whether or not it's as efficacious depending on what it is that you're fixing. So what can and should be done with minimally invasive surgery and peds trauma? The best answer, it depends. It depends on what your resources are. It depends on what your qualifications are, and that changes from day to day. But it's something you should keep in your mind as a possibility. But remember, the current gold standard, and I think it always will be, for any unstable patient with blunt or penetrating abdominal injury is immediate exploration and midline laparotomy. And there's not currently an indication for any unstable or non-responding type patient to be rushed in for minimally invasive surgery. Don't do that. If there's any question, just do a laparotomy. Although the people have published studies that where they've done a certain number of them and it turned out fine. Well, Evel Knievel has ran things before. Evel Knievel can do that. I can't even ride a motorcycle without wrecking. So the whole reason we're talking about this is that negative laparotomy has significant risks. Some people think the mortality is up to 5%. I don't agree with that. I think it's lower than that. But even a couple percent is pretty high. The morbidity is certainly probably up to 18%. Adhesive bowel obstruction. Now, if you operate on somebody's abdomen and they're 60 or 70 years old, their exposure window as far as how long in the rest of their life they're going to get a bowel obstruction or some problem with that is a lot less than someone who's 5 or 10 years old and then has 7 decades to get a bowel obstruction or develop a hernia or have issues with that. So when you look at it from that standpoint, the morbidity is probably more of the argument than the mortality. The mortality, it's missing an injury that's a problem, not as more so than the scarring. Let's see. Okay. So there are proponents for this in adults who say that in their adult studies they have a significantly shorter hospital stay, it costs less money, and that they have no increased risk of morbidity or mortality, and they even have decreased risk in some studies that have this as part of their protocol. I don't think those are necessarily really strong, super prospective type deals, but I mean, you can argue that, certainly. The accuracy approaches 100%. I would never say anything's ever 100%, but it's pretty accurate if you do it right, especially for certain injuries like the diaphragm. And the patient experiences less fluid shifts. Also have to keep in mind some patients aren't going to be good candidates because of their physiology, and we'll talk about that in a second. But they have had a few studies that have shown that in children, these same benefits can be found. But studies in kids are notorious for having small numbers, and they're not well controlled because it's hard to study kids, especially in unplanned things like trauma and stuff like that, where you have a real question of consent. Okay, so sometimes it sounds like a good idea. Now what? Well, let's go back and talk about kids have a higher rate of solid organ injury. So they have more liver and spleen injuries, things like that, because they have less fat to protect them from the impact of a blunt trauma, or to basically be an area that gets shot but not transmits the bullet. They have less protective muscle mass. Their organs are larger for their size than adults because they still have to grow, and so that liver is doing more than just maintaining whatever the current weight is. That liver is having to metabolize for their growth in addition to their current weight, and so it's bigger than it normally would be. Same thing with the spleen. And their skeleton's immature. It transmits more force. When you go and eat ribs, if you have the baby back ribs, they're the really soft, pliable ones, and it's hard to break. And you're also at Chili's and you're eating with Fat Bastard. But if you have regular bones, you can break them. So your ribs get hit with a hammer, okay? They're going to break, and that break's going to absorb a lot of the injury with that. If you hit a kid with a hammer, it's going to, like this, it's going to bang in, and that force is going to get into that liver or the spleen, and then recoil back, and there's going to be more damage, in theory. So it's kind of a big deal to remember that the thing, an unrecognized, one of the most common causes of unrecognized fatal injury in children is a blunt abdominal trauma mechanism from a motor vehicle crash, meaning kid comes in, you scan them, and you think everything's fine, and they have a bowel injury or some other injury that you didn't appreciate and you missed, and if, in a day or two later they're septic, and sometimes, sometimes they die. And a third of children with major trauma will suffer some type of intraperitoneal injury, so they'll have some spleen or liver or other organ that would make either, let's say, a FAST exam or a CT scan positive. So what is the role of minimally invasive surgery? I think most people would suggest that the role of MIS is basically as a secondary survey issue, or after the secondary survey. You basically got all the airway breathing and all that stuff done. You've identified that these are patients that don't need an immediate laparotomy. They're not unstable. But as you're watching them or you're evaluating them, you find that there is something that mandates getting more information, and you're not sure if a laparotomy is the way to go or not. So it's usually down in this area. It's not up here, at all. If you're not getting past this part of your algorithm and you need a surgery, you don't need minimally invasive. You need maximally invasive. So typical things: penetrating abdominal wall injury. A kid gets stabbed or a kid gets shot, and you think maybe it's more tangential. You're not sure if the bullet or the projectile or even the a knife or whatever went through into the peritoneum. It's great for that. It's excellent for looking for a diaphragm injury because we have scopes that are at angles, and we can see that, I think, better than you can with doing an open. If you do an open, of course you can see all the diaphragm, but you got to move everything out, and you're mobilizing all this stuff. Whereas with the laparoscope, a lot of times you can just get a 45-degree scope and just look around the spleen. You don't have to, be touching it or anything. Thoracoabdominal injury. So if you have multiple areas that are affected and you need to evaluate the abdomen, but you think you have a low suspicion, that you could use it for that. Big use, probably the main use, I think, is for suspected hollow viscous injury, which is basically kid, let's say, is riding in the back seat of the car. They have a lap belt or an adult seat belt that's not properly situated, or they have a chance fracture, which is basically an L2 fracture from hyper extending or bending over from the lap belt holding them and kind of pinching between their spine and the lap belt. And what happens is they rupture their small bowel. And you don't necessarily see that. Like 50% of CAT scans will miss that. So these are the kids that get admitted for like serial exams, watching their white count, looking for fever, things like that. Or if you have a patient who has a worsening abdominal examination and they have on their CT they have a solid organ injury, doesn't mean they don't have a small bowel that's injured. They have fluid, they have a cracked spleen, but it's not bad enough that they need surgery to remove the spleen. But that doesn't mean that they don't have a hole in their bowel as well, and that's causing you to see that fluid. So contraindications, absolutely. If they're unstable or clearly need a laparotomy, there's no reason to even consider it. Relative contraindications, increased intracranial pressure. When you put pressure in the abdomen, you change the physiology of the patient. That may not be the best thing to do for someone who has, let's say, a ventricular catheter in. CHF, we don't have that many kids running around with that have uncorrected cardiac conditions, but if you have a known cardiac condition, you don't want to be changing the preload and afterload with laparoscopy. Uncorrected coagulopathy, you really got to question if you got uncorrected coagulopathy. You don't need something minimally invasive. You need a damage control thing. We'll talk about that. Peritonitis is a question mark. Peritonitis is kind of one of the indications to do it, but they're basically saying if the patient obviously has some major problem, you don't want to be jerking around in there with little toothpicks trying to fix things. Let's go, keep going. This is a protocol that's been put forth as a way of kind of putting minimally invasive in your program. And basically, obviously if someone's unstable, you just go to exploratory laparotomy. If they're stable and you do a fast exam, positive fast exam, stable patient, get a CAT scan, it's your best test. You basically use the fast scan to tell who needs a CT scan. If it's negative, but their liver enzymes are elevated, the lipase is elevated, or they have a seatbelt sign, these are kids that have been identified to be, that fast is not as good at telling. These are kids that may have a parenchymal liver injury, but not laceration that would cause a positive fast, but you would want to know if they have a deep liver injury. Elevated lipase would be blunt trauma to the pancreas. Often you're not going to see a transected duct on a fast exam because you're not looking at the pancreas. And the seatbelt sign carries a high percentage of needing a surgery anyway, so those kids all kind of get thrown back to CAT scan. So if you do find what you think is a hollow viscous injury, those are ideal. You got a CAT scan, you've ruled out a problem with the liver, the spleen, the pancreas, the kidneys, all these other things. You have free fluid and you suspect that they may have, or you see like some thickening of the mesentery and you see thickening of the bowel and you're like, I think they have an injury to the bowel. That's when it's good to use a minimally invasive approach. And then
This is not the ratio, it's the STF more than, not the ratio.
not the ratio, it's the absolute number. And then in penetrating, a little bit more clear cut. I mean, basically, they're stable, fast exams, positive. You could, in some places, they would go direct to laparoscopy. Obviously, if you get shot with a shotgun or you're going through here, you're probably going to need a laparotomy. But in some places, that's where they start. And I think just use it selectively for that. You find an organ injury, you have the ability to possibly fix it with the laparoscope, or you can always convert to open. This is that protocol I said I wasn't going to talk about, but I just need to show that they have these things integrated into overall protocols for blunt and penetrating trauma. And this is based from Arizona, Texas, Oklahoma, Mississippi, Arkansas Consortium for Trauma, as a group of several children's hospital systems that have all gotten together, and they have developed this protocol. I don't know if we currently have anything like this, but everywhere around. And so we're kind of surrounded by it. But anyway, but basically, there is some of this is just expert opinion, and some of this is somewhat evidence-based in how they do it. But it does give you a place to start and kind of how to navigate through these things. And that whole idea is trying to prevent unnecessary laparotomies in these kids that you know have non-operative trauma, and sometimes they'll transiently bleed a little bit and need a little extra time. Instead of rushing them to the operating room, it gives them a reason to kind of watch them. But anyway, it's real busy. There's a lot of stuff in here, but I just put it up there to kind of simulate discussion and maybe something for us to look at if it's helpful. Technical considerations, how do we do that? Use a 5mm 30-degree scope, and it's very important because a 0-degree scope in kids is pretty much useless because you have a small area and it's very hard to see everything with that. You need an angled scope. Start off, the easiest thing is just to put a port in the umbilical area just like you would for any other lap appy, lap chole, anything like that. You can put 2 ports either on the left and the right, equal with the umbilical level. That way you can look down on the pelvis easily, you can look up here easily. Or if you're really considering that there might be a bowel injury, you can just put 2 ports on the left because you're going to focus more on that. Either way, you can do it. It just depends on how you like to do it. The insufflation pressure, you don't usually have to go over 12. 15, you can go up to 15 if you want to, and a low flow rate so that you're not stressing the patient out. First thing we do, we put the head up, the feet down. We look at the liver, spleen, and stomach. You can open up the lesser sac and look in there. You hold the transverse colon up like 2 hands and point the camera down at the root of the mesentery and make sure that you don't have any problem there. You start to run the small bowel. Then you flatten the table out and you turn it left and right as you're running the small bowel. You're taking one grasper over, one hand over the other hand, and that way you're seeing both sides of the bowel. Then you can run the rest of the colon. And then you get Pat and Pennington to hold the patient up this way, and then you can look at everything. You can really see everything very well. The hardest part of this whole thing is when you're running the bowel to not let go of the bowel and then you lose your place. And you got to find out which loop of spaghetti it is that you were looking at and keep going. And so that's kind of that problem, but it works pretty well. So is it therapeutic? Yeah, it can be if you want it to be. If it's less than 50% circumference, you can just do simple repairs. People repaired everything. If you don't like to do intracorporeal type knot tying on the inside, or it's just not your thing, you can just use the camera to find the problem. And then the trick is you look at everything first, okay? Even if there's a small amount of contamination, just quickly finish your survey, find out where the problems are, and then find a port that's closest to the site of the injury and go with a grasper in there and grab the injury, it's usually the bowel that you're working on, and pull it up to that port. If it reaches that port, you'll easily be able to fix it by widening that incision. You widen it to about 3 or 4 centimeters, you can do a colon resection, right hemicolectomy in a kid, just about any size, if they're not adult size, with a small incision like that, basically just by pulling it out of the body, doing all the surgery on the outside, and then just popping it back in. But you won't be able to reinsufflate the abdomen and look around because you've basically made a big hole that the air is going to escape. So you need to look around first and then do that. Whoops, I hit the wrong button. Crap. Okay. Okay, if you're looking for somebody who maybe has violated the lining of the abdominal wall, you can just go in the umbilicus and use a 30, 40, or 45 or 70 degree scope. And that single port sometimes will let you see everything you need to see depending on how close it is to the umbilicus. And if you're worried about missing something that's close to where the camera goes in, just put a second port, or if you don't want to do that, we have some really small scopes, and sometimes they're listed as sinus scopes that the ENT guys will use. You can just take an 11 blade, poke a hole, put your hemostat through there, spread just a tiny bit, and just shove that camera directly through without a trocar, through a tiny hole that you don't even have to close. You can just throw Dermabond on it, and you can use that to look in areas that you can't see. So you really can not have to make a bunch of stuff at all. All right, so any questions on that before we move to this part, the second half of the lecture?
I just wanted to ask a quick question on the bathroom evaluation.
Mm-hmm.
I kind of struggle at the G junction area. Any tips on that?
You mean the GE as far as seeing the posterior?
Yeah.
Sometimes you have to take down, like you're doing a Nissen, sometimes you have to take down the gastrohepatic ligament to look there, and then also the other thing is if you have your port out here, you can use a 30-degree camera on this side and see this left cruce pretty well, kind of like for a Nissen. Okay, so damage control, laparotomy and trauma is basically, it's kind of like something that to me seems like they took a problem and turned it upside down on its head. When I was a resident, we used this had just become kind of popularized. Dr. Smith was telling us we need to start doing this, and it's basically as a bailout strategy. So we would be operating, and then the patient starts getting coagulopathic, they're acidotic, they start doing bad, and then we're like, oh, we got to damage control, and let's get out. And then we'd pack everything off, and we'd stop, and we'd get out. We stole the idea from the Navy, which is basically the idea is just to fix the ship enough to get it back to port so that you can then fix it quickly and get it back in the battle. And that's similar to what we do. But now it's a management strategy. Now, sometimes from the beginning, we do damage control, and it really makes a lot more sense looking at it in hindsight that we start off with it that way. But it's basically the resuscitation and management of a trauma patient who's exhausted all of their, or most of their physiologic and metabolic reserves. The idea is don't be trapped with a patient in the operating room who doesn't have the reserve to survive the surgery, or don't eat up all of their reserves with your surgery because you want to close the bowel or hook this back together or whatever, when you really just need to let them get back to more homeostasis. All right, it's Dr. Zabari. It's a famous hepatobiliary surgeon. Hey, Jake, do what need be done. That's one of his favorite catchphrases of all time. God bless America, rock and roll. Can't let American citizen bleed on OR table. I've heard this 1 billion times from my beloved Dr. Zabari. And so, do what need be done. It's a good example of what damage control is. Uh-oh, time for some old school trivia. What the heck is a Jake? Is a Jake a young turkey? Is it a surgery resident? Is it a funny guy everyone likes? Is it all the above?
You're my boy!
I just want to thank you for being on my service and doing a great job. And always remember, humiliation is admiration. All right, back to wake everybody up. All right. So the critical step in this whole thing is to find out who actually would benefit from and needs a damage control sequence. So the problem with kids and pediatric trauma patients is it's hard to tell who needs it because they're aliens. Kids are aliens. They're different. If you don't take care of kids all the time, they're intimidating. And the problem is it's hard to assess them. It's hard to assess their mental status sometimes. It's hard to know what their blood volume is, what their blood loss is. But basically, the idea is we're just going to do whatever we have to do to keep the patient alive, and we'll come back and fix everything later. So the application of damage control in kids is similar to that in adults. And basically, in pediatric trauma, with the exception of the solid organ injury idea, everything else comes from the adult literature and trickles down to peds surgery, peds trauma surgery. So basically, if it works in the adults, a lot of times we'll start applying it to kids and then we'll modify it to work a little better for kids. And the other reason that is that most surgeons caring for injured children are actually adult trauma surgeons. Most kids are not taken care of in a peds-only place because there are not that many of them. The adult literature is much better than the peds literature. It's much easier to do studies. There's a lot more adult patients to study. So the principles are the same, but the triggers are perhaps different. When I first studied, it was ABCs, ABCs, ABCs. And no one really gave a thought to, well, isn't your spurting out blood like the Black Knight on the Monty Python and the Holy Grail thing going to kill you before we get down to checking your pulse, which we lost because we didn't take care of the catastrophic bleeding? So, it's important to just kind of come back to this. Now, granted, this is usually done in the field. They'll apply a tourniquet, hold pressure, whatever, but it's important to remember that potentially avoidable causes of death most commonly seem to be related to bleeding that's not controlled. And what we're really trying to prevent, and I know this has different terms and things, but what I call the triangle of death. And that's basically the vicious cycle of coagulopathy, metabolic acidosis, and hypothermia. And these things feed on each other. And they all kind of happen at the same time, and they all kind of coexist, but they all feed on each other. Kids are more susceptible to this. Their surface area to mass ratio is smaller. So they're like small ice cubes out in the sun on the hot pavement, melt a lot faster than a big block of ice. Think of it that way. Another thing is, it's hard for us to kind of estimate what the blood loss is. If you ask a surgeon what the blood loss is, in the operating room, he's going to go, oh, it's 20 cc's, and the anesthesiologist is shaking his head because he's looking at the canister, and it's like 200 cc's. You ask, never mind. I was going to do the ruler joke about being married, but I'm not going to. Anyway, the whole deal is kids, their blood volume, somewhere 70 to 80 mils per kg is a good round number to remember. A 1-year-old that's 10 kilos doesn't have a whole lot of blood supply. Blood volume. So, a unit of blood is a third of their, if they've lost a unit of blood, they're in profound shock. phases of damage control, there's 3 phases: a limited operation, resuscitation, and reoperation. So limited operation at the beginning, the idea is just to control the bleeding, limit the contamination. If there's holes in the bowel or anything like that, we staple them off, we quickly sew them off, or we put clamps on them, whatever you have to do to keep it from bleeding. We want to be able to know what all the injuries are if we have time, so that we know how to plan when we come back or when we need to come back. And then you do a rapid closure. Then we go to the PICU, and they work their magic, and they transfuse, and they warm, and they hemodynamically support, and they take this pile of goop that we've created in the OR, and they make it into this nice little figurine that we then take back to the OR and break again. But we appreciate them letting us do that. But then you come back to the OR and do definitive repair. So when's that indicated? A patient requiring, and this kind of mirrors the massive transfusion protocol idea that came about alongside this. A patient requiring a large volume of resuscitation with blood products, and I'll show you the data in a minute, but that's about 40 mils per kg in a child, or about half their blood volume. If you're having to give up to that point, you're in trouble. Profound shock, hypothermia, temperature less than 34 degrees Celsius, pH of 7.2. Now in this article, they used 1.5 as an INR PT ratio, but I've also read something recently that they suggested perhaps 1.3. Maybe you should have a lower threshold, because that was a cutoff where people had a higher mortality from trauma. And then a complex injury mechanism that you know is going to take you hours and hours to fix. Something like an expanding pelvic hematoma that you really can't fix very quickly. A vena cava injury up near the liver, they're very difficult to fix. Or like a head of the pancreas injury or wound. Where do we get the 40 mils per kg idea? Well, basically, overseas in Iraq and Afghanistan, the Department of Defense kept a very good trauma database, and even of the children that they took care of, most of these injuries were blast injuries from IEDs or bombings in the markets and things like that. But basically what they figured out is the inflection point appears to be around 40 mils per kg, so, which is about half of a kid's blood volume. So if you get to the point where you're getting up to that point where you're crossing that threshold, then you need to seriously think that the process that's going on is maybe something you can't control with conventional means. It was a retrospective, obviously it's a retrospective review of a database that was accrued. And most of these were blast injuries, which is not necessarily correlate with civilian stuff here. And then some kids died in the first 24 hours, so that total volume was less because they died before they could get to the volume. But as a starting point, and for further studies or literature, it seems to be a reasonable. 40 mils, half the blood volume. This is the actual massive transfusion protocol from Connecticut Children's Hospital in Hartford, Connecticut. And basically, you don't have to really remember all this stuff, but it's nice that they have a physician judgment indication here. Basically, which you don't have to go by all these rules. If you just have the inclination that there's a problem, they'll let you activate their transfusion protocol. One important thing is 3 of 4 of these: tachycardia, hypotension, base deficit, or lactic acidosis, INR, or low hemoglobin. It's important to remember hypertension in kids is a late finding. Hypertension in kids happens only after they've lost about a quarter of their blood volume. Tachycardia is a more earlier finding and is probably more sensitive. If your child has gotten to the point where they've been tachycardic and now they're hypertensive, you're usually behind the 8 ball. So just remember, if you remember only one thing, remember that. They have all these weird things for how they do. I have no idea why this is 6, 6, and 5 versus 1, 1, 1. I think it's just keep it simple. It seems to me that 1, 1, 1. Is that, Dr. Weigel, what y'all pretty much do? Try to get close to?
Okay.
Matter of convention more than...
Yeah, I thought it'd be like, we just talked about 1 to 1 to 1.
Yeah, I wasn't sure. I couldn't find out why their ratios were like this, but I didn't know if there was something that changed. And then they actually do have some uses for some adjutive therapies, and I guess I can never pronounce it. Whatever, TX, whatever. Some other things that are used in trauma that are part of some protocols and things like that. But there was some advantage to that in kids. So the most common pitfall is just not realizing that you need the master transfusion protocol, not realizing that you need the damage control type of approach, or and then failure to reverse or prevent hypothermia. This is easily fixed. You know, we see this a lot. A kid that comes in, even in the summertime, that comes into this ER is going to be cooled down very quickly because we keep the hospital nice and chilly, and we keep the operating rooms extremely cold, and there's no reason for that. So if one thing you can do is just try to keep them warm. Even if it's on a warm day, they're still going to be hypothermic, especially on a cold day. Or the helicopter is the other thing. When you fly in a helicopter, it gets very cold. Not every helicopter is heated. I think Life Air recently got some new choppers, and I think they are heated. But ones that come from other places may not be, so the kids may come in cold. Things for us to remember is don't jerk around in the operating room. Keep it to a minimum time. And then we need to prioritize procedures. We don't need to let orthopedics come in and set a fracture or wash out an open fracture if the kid's coagulopathic and acidotic and all that. That can wait. But it's always tempting because they want to run in there while you're in the operating room and do all their stuff so that it unclogs their operative schedule, but it's not the right time to do it. Keep the operating room warm. For residents, you want to have a wide surgical prep from the top all the way down to the knees, table to table. It allows you to do just about anything you need to do. There's no role for laparoscopy in damage control, unstable patients with coagulopathic, etc. When you do it, make xiphoid pubis, make a big-ass incision, we call it. Now, some people pack 4 quadrants, some people do zones. It doesn't really matter. However you do it in adults, works the same in kids. But just for discussion, you can pack all 4 quadrants, controlling major bleeding at the beginning, and then you start moving from the area that's least affected or you think is least likely to have an injury to the more injured area. Then you close intestinal injuries quickly. You can just use a stapler, just staple across. It doesn't matter what stapler you use. Just do that, or you can throw a stitch in it. And you want to quickly close the skin or do some type of negative pressure closure. We don't have kid-size aptheras from what I understand. We usually just create our own old school apthera, and there are different ways of doing it. I've always done a 10-10 drape over the bowel and then put towels and drains on it and then IBAN. This group does, they take a towel, they wrap it with IBAN, they put that in the belly, and then they put drains on top of it and another towel and another IBAN. I don't know that it really matters. Negative pressure helps to get the fluid out of the abdomen, reduces the separation of the fascia, allows you to quickly get out. You can do this in like 3 or 4 minutes. You can quickly put this on. Reoperation, sometime between 12 to 48 hours later. No one really knows what the correct endpoint is to come back from the ICU to the operating room. It depends on what the injuries are, the team's availability, what people's preferences are, and a lot of voodoo. But basically, it's going to be your intensivist is going to be telling you they've got them as tuned as they can get them. And once they get to that point, that's when you need to start, before anything else comes up, trying to get it done. And then when you do, you start the procedure over again. You have to be very methodical. This is your chance to really get a good look at everything. Even if you looked at it before, you're going to look at it again, because missing injuries and open abdomens is common because you're just trying to get in and get out. And then Samra asked me this, which was basically, what's the volume of blood from a chest tube that mandates a thoracotomy? I didn't talk about damage control thoracotomy because it's not very common. But basically, if you have an adult-sized child, use an adult-size criteria, because basically 70 mils per kg is roughly, adult blood volume, somewhere in that range. So if it's greater than 1.5 liters when you first put the chest tube in, after that, if it's greater than 2, or if after you put a chest tube in, you're getting 200 mils per hour out for 2 consecutive hours up to 4 hours, that's when you start thinking that, well, maybe something in there is bleeding that's not going to stop bleeding on its own. In a small kid, or if you're not sure, you can use the 15 mils per kg initial output from the chest tube, or 4 to 5 mils per hour is what is generally recommended. And that's the end. Y'all have any questions? Deadpool 2 is going to come out sometime. I'm excited. Anybody here watch Deadpool? I'm not killing the teddy bear. It's interrogating the teddy bear. It's asking, where are the cookies? I don't know. It's trauma related. There's an adult. Yes, sir.
Just a point for particularly pediatric people. There's a great study out of Montefiore in New York where they looked at mild, moderate, severely injured children and looked at their resuscitation And of the severely ill, the severely injured children, only 25% got initial resuscitation, only because they had normal vital signs.
Yeah.
And so just to take home, the normal vital sign in a child does not mean anything.
Yeah.
And once they hit, like you said, any bad vital sign, they're already behind the 8 ball.
They have
So-
fallen off the cliff.
Yeah.
Yeah, they can
Already fallen.
compensate tremendously, you know.
Compensate, and then they don't.
So it's, and that's a good place.
Yeah, exactly.
So,
Yeah, it's hard. I think that's really the main problem is, I mean, I think most of the time, if we have a good idea of what's going on, we know what to do and we do it. It's just that with specifically that problem. And when they come in hypothermic the other thing I didn't mention is in blunt trauma, head injury is so common and it confounds all this, and that makes it more likely that you may need to do a minimally invasive look because you have somebody who's basically obtunded, can't tell you if they have peritonitis or not. You think they're doing worse, you're not sure, the original CAT scan was weird, maybe a follow-up CAT scan's weird. Those are, uses for that as well.
for serial CAT scans?
I don't know, that's a good, I guess if the initial one's negative, but I would think at some point you're going to have some fluid if you're, maybe if you're resuscitated a lot. I don't know what that fluid would mean. But
I'm just asking.
I mean, I know there's some, now there is, and I haven't read up on it, and I need to ask the radiology folks, there is contrast enhanced ultrasound. I don't know what exactly that means, but
They have
for,
different, just particles that are ultrasound reflected.
and I don't know how you would do that in a general sense of things, and
It takes too long.
yeah. Is that where you shake the albumin type idea? Is that, make the bubbles?
Yeah, that's a different part, there are different.
Okay. Yeah, I mean, there was like a brief blurb of that, there are some advances in ultrasound that may make it a little bit better, but the main problem is fast exam's looking for fluid. Lots of things cause fluid. It doesn't necessarily tell us what it is. Sometimes on a CAT scan, fluid's been there for a while. You can look at the Hounsfield units and see if it layers out and stuff, but even then, you can have a spleen injury and a ruptured, jejunum in the same patient, and you're not sure which is which. That's
I think the other thing from the PIC perspective is, and I think we fall behind, is quickly rescanning. Even though, yes, radiation that, but they're iffy in that.
I don't see the big deal.
I mean,
people now.
No, but rescanning, because we have dosed it down considerably.
Yeah, we don't know if the changes we made, if it's, the same level of risk. I think they were quoting like every 1,000 CAT scans is one kid that can cause cancer. I mean, I don't know, but if it's every 1,000 CAT scans of a trauma patient can cause one cancer, you're probably doing more good than harm. Maybe I can see for appendicitis or something else, get away from that, but for trauma, just don't have much of a room for error.
The last I looked at that, because we did something for head stuff, it's moving more towards 1 in 10,000 instead of 1 in 1,000 the last I saw, but that's, like you said,
It gets to be hard to prove,
Right.
The correlation. But I think the idea sound, why not limit it? It's, it's kind of like, I don't think CO2 causing the earth to form. CO2 is something that we also do when we pollute stuff, so maybe we should cut back on pollution. That's somebody else, sorry. Anybody got a question?
DJT's going to be tweeting about you this way. We're going to do tomorrow. Donald J. Trump.
Oh. Well, sure. I'll be quoted as a source. Many people have said, that's your favorite guy.
I would assume that a follow-up CT scan, the normal value, would be looking for air.
Yeah, I don't know what
The
that.
fluid is fluid. You're probably going to see a solid organ injury on the first scan, although some of the kidney scans have gotten to the point where it's almost worse than not living.
Yeah, I don't think they should dose it down if it's going to give you a quick presentation. It's not supposed to, but I think sometimes people, they don't protocol it right, and, that sort of thing, but, anyway.
Anyway, if you're looking for a bowel, the thing you'd be looking for on a second scan would be most likely bowel injury,
Yeah, and if you see any air, that's pretty,
or I guess a big collection of pancreas.
yeah, it'd be a problem. But anyway, okay, well, thank you all very much. Have a good weekend.